Hi, everyone, and thanks for being here again today. I'm Lisa Juckett, an investigator with LeaRRn, and I'm pleased to introduce today's presentation in our series, Using Health Systems Research to Revolutionize Rehabilitation Care. And please note that if you would like to enable closed captions for this webinar, there are two options in the Zoom navigation bar. You can either select Show Captions if it's visible, or if it's not visible, you can select More to access the closed captioning feature and then select Captions. You can then choose your preferred language. Today's webinar in our LeaRRn series follows three webinars presented last fall featuring Dr. Anna Baumann, Dr. Leo Cabasa, and Dr. Amanda Botticello. The presentation recordings and resources are available on the archived events page of the LeaRRn website, and you can view all archived presentations by using the link that was just entered into the chat. Our speakers today are Dr. Jennifer Oshita and Dr. Chloe Slocum. Dr. Oshita is a postdoctoral fellow at NYU Langone Health in the Department of Rehabilitation Medicine. Her research aims to improve high-quality healthcare for people with disabilities. She strives to conduct participatory and partnered research to design interventions which effectively implement health policy, addressing communication access and health-related social needs. And her co-presenter, Dr. Slocum, is the Associate Chair for Quality and Assistant Professor at Harvard Medical School's Department of PM&R and Director of Health Policy at MassGeneral Brigham Spaulding Rehabilitation Network. Her clinical work centers around optimizing long-term health for individuals with paralysis, and her research is focused on assessing functional outcomes following rehabilitation, access to high-quality primary and specialty care, and systems of healthcare delivery across the post-acute care continuum for individuals with disabilities. Our presentation today will be followed by a Q&A session, and we ask that you please enter your questions in the Q&A feature of Zoom so that we can address them once the talk concludes. After the presentation, we will provide a link to an evaluation survey, and we'll conclude our time today by sharing information about upcoming LeaRRn events and funding opportunities. But before we begin, I think we've got maybe an agenda slide to follow this, but then quickly after that agenda slide pops up, we have a few poll questions just to get a sense as to who is in the audience today. And so once those questions come on the screen, take a moment to check them out. And then if you wouldn't mind giving us your responses. First, by telling us your primary affiliations, whether you're in an academic or research institution, health system, federal state agency, or another entity. Our next question, if you wouldn't mind selecting the response that best characterizes your organization's efforts regarding implementing social determinant of health data collection efforts. And then lastly, if you wouldn't mind telling us how your organization is currently using social determinant of health data. And we'll give folks a few more seconds to fill those out. Got a good spread of different attendees here. It looks like these data bars on my end have somewhat stopped moving. So maybe we can go ahead and end the poll, see the results. And we've got, similar to what we've seen in past webinars, a fairly even split. Got about half folks in academic and research institutions. And again, you might be in more than one, you might have more than one affiliation. 55% in health systems, 7% representing federal and state agencies, and 5% other entity affiliations. When it comes to how your organization is deploying data collection efforts regarding social determinant of health information, it looks like the majority, well, 38% are in the early implementation phases, 33% planning phases, and 15% for both fully implemented, which is exciting, and then 15% not yet applicable. And then our last question here, how is your organization currently using social determinant of health data? So not just collecting it, but actually using it. 36%, so just over a third for internal monitoring, just over a third for to inform care planning, intervention development, 21% required reporting, 41% for research, and then maybe roughly another third for another purpose or not yet collecting. So thank you for telling us a little bit about yourselves, the organizations that you represent, and how you're using some of these data that are going to be applicable to the conversation that we'll be having later today. And so now I'll go off camera, but I'll invite Dr. Slocum to come on camera and to kick us off with the main event.
Thank you so much, Lisa. And it's great to have everyone here today. I'm Chloe Slocum, and that was a really generous introduction. I'm honored to be here with my esteemed colleague, Dr. Oshita, and to share some of our work over the past several years. This has been exciting work. It's not necessarily new, but I think in terms of the operations piece of it and really implementing it widely into clinical workflows as opposed from a more investigative research paradigm has been really exhilarating and also at times challenging from a practical perspective. And so we're going to talk about that with you all today. And as I said, we here at Spaulding have really benefited from Dr. Oshita's expertise and her perspective, and that has helped us immensely. Next slide. So I will talk a little bit about social factors and health outcomes. So just some basic vocabulary terms, sort of demystifying some of the alphabet soup around social determinants of health and health-related social needs, as well as what we know and why they're important. And I'll also talk a little bit about how collecting information on health-related social needs really drives value, and what we know a little bit in terms of the value of healthcare in the U.S. Next slide. So our objectives today will be to describe how social factors and social determinants of health and health-related social needs impact health at both community and individual levels. Describe several health policy initiatives related to improving collection of health-related social needs data across healthcare settings, so really in the clinical domain, and to identify potential barriers and solutions to this screening. And Jen will talk about sort of the nitty-gritty of sort of our practical approach with teams at Spaulding and how we made some of our decisions and mapped out some of our processes using data from frontline providers. Next slide. So what do we know? So the CDC defines, oh, that's okay. You can go, yeah, thank you. What the CDC defines social determinants of health as conditions in the places where people live, learn, work, and play that affect a wide range of health and quality of life risks and health outcomes. So the World Health Organization also defines them this way, but also goes further to really contend that these circumstances are shaped by the distribution of money, power, and resources at global, national, and local levels, and that they're largely responsible for health inequities or what we could argue are the unfair and avoidable differences in health status seen within and between countries. And we'll get into why this is also important for value. Go ahead. When we think about social and structural determinants of health, we can sort of think about them at the individual, the community, and sort of the more macro societal level. So health-related social needs are really specific to an individual. When I am in a clinical encounter as a physician with a patient, their health-related social needs are really unique to them. It may be the transportation resources that they individually have. It may be that their individual level of education. It might be their particular health insurance. It might also be their social and family supports. The grocery stores that, they particularly have access to and might be sort of both acceptable, but in terms of their personal preferences, but also, what they choose to go to. And then when we get into social determinants of health, we're talking about the community level. So it might be the level of a neighborhood. So within a particular zip code, what resources are there? neighborhood safety, things like housing stability and living conditions, whether there are parks nearby or sort of places that you could go to participate in recreational or fitness activity, and then social and community resources and supports. So for instance, what programs are available within a particular city, within a particular metropolitan area. For instance, what activities are available for seniors in the, for instance, the Dallas-Fort Worth area. Something like that. That is a social determinant of health, and that's at the community level. And are specific to a community or a neighborhood or a particular area, whether you break it down in terms of geographic area or municipal jurisdiction, what have you. So structural determinants of health are sort of broader at society level, and they can be related to things like laws, policies, institutions, societal norms, and systems of power that might be bigger than a particular individual municipality or a particular zip code. But when I think of structural determinants of health, I think, for instance, of how we decide, transportation structures. So where do we have bus systems that run? We don't have them that run all the way out to rural areas sometimes. Housing policy in terms of, obviously zoning policy is very different in terms of single family dwelling, multifamily dwelling. Accessibility is a big one in terms of whether accessibility is even sort of required in terms of construction, and then things like school funding. So these are all sort of bigger structural things that we are contending with. Next slide. Why do we care about this? So as a physician, I spend a lot of my day, in individual clinic visits, but it's humbling because we know from really broad public health data that long-term health outcomes really are only related to, clinical care and about 20% of the outcomes in terms of that's the care that I'm delivering, the care that sort of is within the health system is responsible for about 20% of health outcomes. Much more responsible for long-term health outcomes are things like social and economic factors, as well as the physical environment for respectively 40 and 10% of health outcomes. And then 30% is sort of responsible or is can be tied to health behaviors. So things that are more choices or behaviors that people are making. However, those can also be influenced by things like social and economic factors. So this is really important if I'm really want someone to implement a care plan successfully, or if I really want to understand how to motivate and influence positive behavior change in my patients. It behooves me as a clinician to really understand what kinds of social and economic factors they're contending with in order to have the best possible chance of success. And so I have to understand their education, their employment, what they're doing for income, and their level of family and social supports, and things like community safety in order to develop a plan with them, and to be confident that they will be able to implement that plan. Next slide. Dr. Oshita is going to talk about this slide, and then we're going to flip back briefly before she gets into the work that we did at Spaulding.
So just in giving us all a context and a background on social needs, but specific to the rehab population. So I had looked in the literature and there just wasn't a lot existing on the likelihood or prevalence of social needs amongst people with disabilities. So partially instigated by this work, my colleagues and I used the National Health and Interview Survey and just looked at the likelihood of experiencing social needs by any difficulty communicating, any difficulty with self-care, any difficulty seeing, any difficulty walking or climbing steps. And on the x-axis, you can see the odds ratios here. And then on the y-axis, you see the different social needs. And across, I think the big takeaway from this slide is just that across social needs, maybe with the exception of internet here, which is, most of these are at odds ratio of 1, but for the remainder, and I should also mention that this is after adjusting for sociodemographic characteristics, rurality. People with disabilities have an increased likelihood at the magnitude of 1.5 to 2.5 odds of experiencing a social need when compared to people without disability. So I think this just goes to show how important collecting social needs is for the patients that we serve, because they experience these social needs at higher rates than the general population.
Thank you so much, Dr. Oshita. And it's fantastic work by Dr. Oshita and colleagues, including Dr. Morris. So again, why do we care about this? So, recently, I would say sort of within the past 15 years, there's been more and more of a focus on value in healthcare delivery. So I mentioned outcomes, but thinking about really outcomes and how they relate to cost. So broadly, not just the American Hospital Association, but sort of health economists and health services researchers define value as outcomes and patient experience. So whether that's, health outcomes in terms of health status, health-related quality of life, or patient-reported experience, maximizing that to the fullest extent possible, while also keeping care affordable. And this doesn't incorporate indirect and direct costs. We could have a whole discussion about that, but the sort of costs broadly being contained, or at least containing the rate of growth of costs, since we know the cost of everything is growing. So trying to, at the same time, maximize the numerator in this equation and contain the denominator, or at least not have it grow as rapidly as we are improving outcomes and patient experience. Next slide. So we really care about this because there's a lot of information from our colleagues, for instance, at the Commonwealth Fund, but even sort of within the OECD and some of the World Health Organization analyses, that US care from a global perspective is modest, to be generous, in terms of the value it's providing. Next. So we know that the US here, and you don't even really need your glasses to read these graphs, but the US here sort of take home is at the top of the curve when it comes to healthcare spending. We're an outlier here in the top graph in the middle. And yet things like life expectancy, things like maternal mortality is lower relatively. So we are at the bottom. Again, you can sort of very clearly see. And so when we think about value, we are in the wrong direction in terms of where we want to really drive this. And we have sort of more expensive care and more expensive or more higher spending overall. And yet our outcomes are not keeping pace. So we don't seem to be getting the value out of it that we would be expecting based on our spending in the US. And it's important because if we go back, think back to that, the counties graph in terms of thinking about where, like, what are opportunities? What are the gaps in terms of where we could be focusing? Health-related social needs is one of those, and so trying to characterize those and trying to act upon those in a meaningful way can be really powerful. Next. Okay, so there have been several health policy initiatives, next slide, looking at how we can sort of address these. So within clinical settings, the National Academies had a really nice framework of how social needs can be addressed. And we can adjust our care processes. We can assist our care processes. These are all focused on the individual. So an example of adjustment would be screening for health-related social needs, screening for disability accommodations, and then assistance might be providing assistance at the point of care for the individual. Adjustment could also be adjusting our care processes. So having adaptable equipment available, also, for instance, training individuals to provide disability competent care could be another example of adjustment. And awareness as well, focused on the individual and the community, but sort of bolstering our awareness, understanding what is the community prevalence of specific types of disabilities, understanding the community prevalence of specific types of health-related social needs. So it would be powerful for me within my health system to understand, if folks who are north of the city who carry a diagnosis of stroke or hemiparesis are really struggling with food insecurity, that's something that we as a health system can not only work to assist individuals we serve, but we can also advocate for them. So this comes into the lower quadrant on the right here. Sort of actions that can be taken to focus on the community include advocacy and also alignment in terms of aligning with existing initiatives or aligning our processes to help serve individuals that are affected better. And this is powerful, I think, to think about as an individual clinician, because many times our clinicians might be overwhelmed, or they might say, well, I can't think about that, or I wasn't trained to deal with that. And realizing that these advocacy and these alignment components really are, a real opportunity for the system to advocate, and not simply the domain or the purview of any one individual provider to resolve by themselves. Next slide. Health policy initiatives that aimed at improving health-related social needs screening include things that carry positive financial risk, a neutral financial risk, and then a negative financial risk. So on the positive side, and you can advance the animations. For instance, in Massachusetts, we have a Medicaid or a Section 1115 waiver support, which allows our Medicaid program to be administered in a way that we have certain ways that we're allowed to modify it. And so under that, Massachusetts has decided to require hospitals to collect health-related social needs data, as well as disability-specific data on patients in Massachusetts. And so we receive an incentive payment related to that if we meet those criteria and if we engage in those activities. Relatively neutral, although we could say sort of it does carry a financial risk to it, albeit indirect, would be sort of these accreditation and standards-based changes that we see. So you can advance to the next animation. The next one, sorry. The elements of practice, or the EPs by the Joint Commission, now include several new EPs that are related to leading activities that reduce healthcare disparities and collection of things like social determinants of health and health-related social needs, as well as the Office of the National Coordinator for Health IT, or ONC, now includes health-related social needs in their interoperability data standards. Within the negative risk, CMS is now requiring, or has required since 2019, inpatient rehabilitation facilities to collect information about transportation. And as of 2026, we'll be requiring them to collect information on food insecurity, difficulty paying utilities, as well as housing instability. So sort of growing momentum around that, and a realization that this is really important for delivering high value care.
Okay. Thank you, Dr. Slocum, for that great introduction to social needs, the evidence and policy behind this practice that really served as the impetus for this work. So in the second half of our presentation, I'm going to share with you all a brief background to our project titled The Screening for Health-Related Social Needs at Spaulding Rehabilitation Quality Improvement Project, which we've been calling SHINE. I'll share with you a brief background, the methods, and finally the findings from our work. So this project was made possible through the Learning Health System Rehabilitation Research Network Scholar Program. I had the good fortune of being a scholar and paired with Spaulding Rehabilitation. This is a one-year project that began in May of 2024 and is ongoing. Early on in our meetings, in our scholar and organizational partner meetings, we decided to focus in on social needs screening and the acute rehab setting. And this was due a lot to the impending CMS policy requirements, which really made it an organizational priority. And this is the requirement or linking consistent collection of social needs to reimbursement. So like many medical settings, especially in the rehab world, social needs screening is really a newer practice, and this was the case for Spaulding Rehab. When I came on board, the practice had been evolving for roughly 2 years, and Spaulding leadership had already begun to more tightly define the parameters of this new practice. So for the first parameter is, what are the questions that should be asked? And so the questions that Spaulding landed upon addressed 5 content areas of social needs of food, transportation, housing and utilities, financial constraints, and internet access. They selected 9 questions that were a part of the Centers for Medicaid and Medicare Services Accountable Health Communities tool, which is their version of a health-related social needs screening tool, as well as the Prepare, which is another frequently used social needs screening tool. And these were also guided by options offered through the Spaulding EHR vendor, Epic. So the 9 questions, I'll read one question from each content social need area just to give you a sense of the questions. So for food, within the past 6 months, we worried whether our food would run out before we got money to buy more. Transportation example is, has the lack of transportation kept you from medical appointments or from getting medications? And then in housing and utilities, what is your housing situation today? Financial constraints, do you have trouble paying for medicines? And then in internet access, one example question is, do you have reliable internet access at home? So all the responses for these, for most of them, the responses are yes, no. The exception is for food and housing. There are multiple options from which the patient can select one. And then in terms of the mode of delivery, due to the nature of the patient population, Spaulding decided these questions would be verbally presented and read aloud to patients rather than presented in a written form, as is often done in primary care settings. And finally, in the who delivers this screening, there was an evolution in role delineation over the 1.5 years of this project, or that this project looked at or examined. And primarily the 2 primary screeners were between case management and nursing. And really midway, leadership decided that case management was the best service to provide this screening, particularly because not only does every patient in the acute rehab setting have a case manager, but that case manager stays constant throughout their stay, and they're probably linked to more of those social resources than nursing, who has a better hold on that clinical care. However, I should say that nursing did serve as a backup screener if case management was not able to screen, and then if case management identified an outstanding social need, also known as a positive need in the CMS language, then case management referred that patient to social work, especially if it was a more complex and chronic need. And so social work then played a role in responding and addressing the outstanding social needs. So that was the practice that we were looking at and examining implementation of. All right, so this slide, Dr. Slocum already reviewed the National Academies of Science 5 A's which are kind of like the purposes, the goals of why do we even screen for social needs. We don't collect social needs for the sake of collecting them. Like, there should be a return on investment to patients on this data being collected. So I like this model because it keeps the why of screening close at hand. How are we serving patients in meeting their social needs? And I really use this model as I designed the project as well as in analyzing the data. Now, specific to SHINE and the pilot efforts at Spaulding, the focus within these 5 activities of social needs were awareness, so just identifying and flagging more consistently and systematically which patients have social needs, and then providing assistance for those social needs. So those were the 2 whys of conducting social needs screening at Spaulding Rehab during this pilot project. Okay, so the goal or the research project question that we looked at here was describing social screening practice and factors impacting adoption in acute rehab settings. So that was the goal, and I should say that this is actually a quality improvement project, so it wasn't technically research because we were really focused more on the institutional goals and needs around improving their local quality of care. And we took this approach because we weren't testing a hypothesis. It's pretty low risk. We wanted to have that flexibility and adaptability in the design of our project, as well as being responsive to organizational needs. So there were 3 phases that we defined up front, and these are more general. And again, we left room for adaptation along the way that could be dependent on findings from the prior phase. For example, so phase 1 was really the quantitative kind of screener level of looking at EHR data to hone in and narrow down the level of analysis that we would be focused on, because our primary data collection that we would be using to answer our project question of what is the social screening practice look like and what are factors to adoption, that we're really going to gain from phase 2. But phase 1, through looking at the EHR data and the quantitative data, we would be able to hone in on which level. Would it be organizational level factors, setting level, floor level, patient level characteristics, clinician level? And this was a 1-year project, so we wanted to ensure the scope was feasible and reasonable. And then after we identified that level, we would conduct the qualitative interviews, honing in on that level of socioecologic impact on adoption to social needs screening. And then finally, the ongoing phase that's currently underway is phase 3, where we are co-designing with stakeholders specific to that level and pertinent to the factors that arose in phase 2 to design implementation strategies. So in phase 1, again, we selected our level of analysis, and we did this through a quantitative EHR data pool across Spaulding's 2 acute rehab sites, which are Cape Cod and Spaulding Boston. And we also unit level differences, patient level QI, we stuck with Epic Slicer Dicer, which only provides aggregate information. You can't link data to a specific patient, and there's no identifiable information there. And then our outcome was what percent of, by these levels, what percent completion did we find of the social needs screening fields? And in terms of how that was measured, we had a low bar. It was really if any one of those questions was documented, we counted that whole social needs screening field as a completed case. And that's because, this was an emerging practice. So we wanted to just think about from this emerging practice level, what's happening with adoption. And I should say the time frame that we were looking at was from February 2023 to August of 2024 last year in terms of the EHR data pool. So what did we find? So Spaulding Acute Rehab, overall, the social screening adoption rate was 51%. Now we had that average across 2 sites, but so we wanted to see, okay, where there are site level differences, explaining this average. And indeed, there was quite a big difference in site level adoption rates, with Boston being at 16% and Spaulding Cape Cod being pretty high, 86%. And this Cape Cod was then meeting kind of leadership goals of being at least above 80% during this pilot phase of adoption. Ultimately, leadership is hoping for 90%, but this is where Spaulding leadership hoped to be during this time frame. Now, from the site level differences, we wanted to drill down further. Okay, were there floor level differences or units? And Boston has seven floors, but 6 of those adult floors, and Cape Cod is 2. And across those floors, you can see that the range was not terribly wide for each site. So it didn't seem like floor level differences were driving this site level finding. Okay, and then we want to look at, okay, are there patient level characteristics driving these differences? We know that Boston does see more patients with neurologic brain injury and after stroke. Boston also has a more diverse age, race, and insurance mix. But we didn't find a lot of variation by these characteristics. And, so on the positive note, there weren't disparities at the patient level by patient level characteristics in terms of screening adoption. So we could kind of rule that out as a major driver at this stage in the analysis. Then finally, we wanted to look at clinician level differences. So it looks a little different here because the denominator is different. The denominator here is just of all screenings completed here. So here in Boston, there were 658, and Cape Cod 1,574, and Boston is much larger, so this should be a larger number. But again, remember that Boston only had 16% completion of all patients admitted over this 1.5 year period. So, so case management was expected to be the primary screener, and you can see of all screenings completed, case management at Boston was not the predominant screener, was nursing. And at Cape Cod, case management was, and nursing was kind of secondary. So this is kind of what leadership hoped to see. I should say, just mention that this is slicer dicer data. So we did have quite a few number of missings in the data. And Cape Cod -9%, just as they did such an amazing job that there was actually duplicative documentation where sometimes both case management and nursing documented on social needs screening. But all this to say that from this phase 1 quantitative analysis, we really found the greatest differences at the site level, so between Boston and Cape Cod, as well as the clinician level. So as an outside researcher, coming into this project and seeing those differences, I thought, oh, well, could we compare the two sites? Like the Cape Cod is this bright spot and Boston could learn from Cape Cod. But after discussing with my organizational partners, they really felt like that the two sites, Boston, Cape Cod, are just completely different, sites or institutions, and that went across the size of the institutions as well as the patient makeup and even the clinician demographics as well, the culture of each setting, just due to the metropolitan nature of Boston versus the more rural and remote setting of Cape Cod. Other examples, when you actually look at the demographic data and setting level data, Boston has 120 beds, Cape Cod is 60, and Boston is just more heterogeneous across age, race, insurance, more neuro heavy. And Cape Cod is just smaller and more homogenous of a population. So we decided that this wouldn't be a fair comparison. And we just decided to focus in our efforts on Spaulding Boston. Again, this is a one-year project, and focus at the clinician level, primarily case managers, but secondarily, we wanted to get some other clinicians who are involved in this practice, mainly nursing and social work, and the patient voice as well. So phase two, phase one helped us to narrow down our sampling for qualitative interviews in phase two, where we could really use this data to understand what the factors were impacting adoption of social needs screening. So our methods in this phase were to conduct semi-structured focus groups and interviews between 45 to 60 minutes in length. Again, we interviewed primarily case managers, some social workers, and one nurse. We also spoke with the Spaulding Boston Patient and Family Advisory Group. Our question guide was informed by the LeaRRn Prism, as well as the needs of the Spaulding organization. And then our analysis, we transcribed the data and used deductive and inductive methods. So we categorized the data using LeaRRn Prism, using a matrix analysis. But within the columns, we felt like there needed to be another more nuanced level of specification. So at that point, we also coded within the column, focused on the awareness and assistance goals, and coded by the who, what, where, when, why, and how of awareness and assistance goals. And then finally, once we arrived at our themes, we went back to the case managers to conduct member checking. All right, so our participants, we conducted 3 focus groups, 4 one-on-one interviews, again, primarily case managers, but a total of 17 participants. All right, so results, qualitative themes on what were the factors impacting uptake of social needs screening. So theme 1, across clinicians and patients, interviews and focus group, there was really the sense of there's some discomfort around this practice. And the discomfort for clinicians centered around the fact that the questions were focused on like past as well as current, as if the current was just kind of stable. And this is a mismatch where patients are coming out of oftentimes acute, unexpected traumatic injuries, or traumatic or sudden injuries, and it just didn't fit where patients were in terms of processing as well as the unknown of meeting social needs. So this quote says, they're so focused on the here and now. And, I just got to this acute rehab hospital. Am I going to start walking again? Can I get my full speech back? The other sub-theme around the discomfort was this uncertainty that assistance would be effective. So this quote says, acknowledging the need and then providing a list of resources can sometimes feel floppy, like there are shelters or there are rental assistance programs or what have you, but the issue is much bigger than that. And so, there's this uncertainty around trying to address social needs, which are in and of themselves complex and often have some level of systemic issues, and trying to address that within a 1 to 2 weeks stay, which is short, seems pretty challenging. Patients, they felt like there were concerns around how would this affect the privacy of their information? Who would this information be shared with? Like, would this be reported to anyone? Would this be revealed in their electronic health record? Would family members have access to it? And they also wanted to know, will I be kicked out of rehab early if I reveal that I have financial constraints? So there's this concern with length of stay. And this kind of actually bridged both patients and clinicians, was this lack of clarity on how social needs information would impact discharge planning. Clinicians were worried that by asking about social needs, they would be setting up false expectations around discharge, that the discharge date could be flexible around social needs, and if social needs aren't met, then maybe we could extend discharge, which was not the case. And then the case managers were also worried that this could also affect how honest patients were with disclosing their social needs. The traditional underlying focus of acute rehab, because it is this transitory phase of care, is, okay, what does this information do and how does it translate to discharge planning? And that question for social needs wasn't unanswered at this stage of the practice. And then for theme 2, this was around awareness within the acute rehab stay. So clinicians felt that for the goal of awareness, this was met within the acute rehab stay and within the acute rehab team. So this one says, now that it's at the start of an admission versus as the length of stay progresses, which is the past practice, that's definitely important in identifying what might need to be addressed sooner than previously had been arising in the past practice. And this went for patients as well as clinicians. So this clinician said that they appreciated that this planted the seed for patients that we need to start thinking about these realities, because 2 weeks isn't a long time, and we don't start thinking about it now, then we won't be able to set you up for success if it's just discovered at discharge. However, the issue with this is, while this is a positive thing in terms of within the acute rehab stay and building awareness, that awareness doesn't transfer over to the next level of care, because the primary tool that's used to communicate findings within the acute rehab setting is, actually across the continuum of care. But in the acute rehab setting, the case managers documented outstanding social needs or met social needs on this wheel, and you could see each of these icons represents a social need, like transportation or food, and green means no problems, but orange or red mean there is a positive need. And this really reflects, this is a expansion on a longitudinal view across the continuum of care where outstanding social needs arise. And clinicians said that because the practice is, we're asking these social needs upon admission and not at discharge, then the social needs are actually reflecting what was happening before this injury. And it wasn't capturing all of this rich information developed by the team and the patient, in partnership with the patient, in terms of how the patient's chronic social needs intersects with the new functional impairments by this patient, and how that all then intersects and results in impacts on social needs. All right, and then theme 3, assisting with social needs, is a shift in prior acute rehab approach and requires more resources. So one clinician said that the difference in this new practice, while they've always addressed social needs, is before it was very narrow to barriers to discharge, and now with screening for social needs more broadly across these 5 content areas, they are looking at this preventive approach of barriers to success. And they said there are assets to this approach. They appreciated having and seeing the person as a whole, not just them being here for rehab and setting them up for success. But they felt like there were insufficient resources for this. And because of that, they felt like they got stuck when there's a barrier to success, like food insecurity, but that's not a barrier to discharge. You're still going to be discharged even if you have food insecurity. So case managers felt like there were more resources needed, and especially more disability-specific resources. One clinician said the information's out there, but it's varying degrees of information based on years of experience. And these resources are often changing in the community. And it's so complex because it depends on the patient's age, insurance, geographic location, and for acute rehab, also disability, right? It's not just providing transportation resources, but it's accessible transportation that can accommodate a wheelchair. It's not just providing Meals on Wheels, but can this Meals on Wheels service provide pureed food for a patient with dysphagia? All right. And then in our final theme, clinicians were finding ways to adapt, but this was really on a case-by-case basis and really varied how clinicians were adapting. But these adaptations including asking questions in a more conversational manner. They were not following the wording of the questions, which are kind of asked in this past tense manner. They also provided scripts to frame why questions were being asked, and they distilled the information down to ensure the information was not overwhelming because of the acute nature of the processing that the patient was in or is in. And specific to this, the clinicians said that it was often difficult, or it is often difficult for patients to process this level of information. And then finally, in terms of ways to adapt, they were really needing to adapt for patients with cognitive and communication disability. And this is cognitive and communication disability due to the acute condition, whether it's stroke, TBI, some neurologic conditions, as well as older adults who just have maybe age-related cognitive decline, and that could really impact both screening as well as providing assistance. And this quote talks about how this patient has the resource of the LeaRRn, which is a paratransit service, but it was just too complicated for this patient to use, and so they just never used it, and it was ultimately not a resource for them. All right, so those were the themes, and then I just wanted to quickly go over how in this discussion section, how our themes in this acute rehab setting aligns with prior evidence, which is really developed upon the primary care setting. So there was a lot of overlap overall and a lot of alignment with our findings. And so the first area of alignment was that both primary care and acute rehab settings, clinicians reported this sense of discomfort. And the overlap is that there is a concern around negative patient perceptions, around clinicians feeling self-efficacious around screening. But the nuance specific to Spaulding Boston was that there was this mismatch between the pre-injury focus of the questions with patients processing of their new acute medical condition. And then in both primary care and acute rehab, there is this uncertainty that patients' needs could be met specific to acute rehab. This was related to the goal of assistance in that acute rehab is a short rehab or short length of stay. And currently the resources were insufficient to address social needs, especially related to disability. And then totally new to the acute rehab setting that was, I didn't see in the primary care literature, was that both patients and clinicians wanted to know how would the social needs information affect discharge planning. And there was a gap in how would awareness information be transferred over to the next level of care. And this was so important in the acute rehab setting where there's just this rich information due to the intensive team-based nature of this setting and how they could really provide valuable information on this acute condition, but it wasn't necessarily being transferred over to the next level of care. And then finally, in overlap, clinicians felt that the screening tools were complex and similar to the primary care setting. You know, this could be due to literacy and language levels, but the nuance in the acute rehab setting was for patients with cognitive and communication difficulties. And then finally, in knowledge of community resources, you know, this was a barrier in both primary and acute care settings, but specific to Boston Acute Rehab, this came into play in terms of disability-specific resources. All right, and then what we're doing right now is in our phase 3 is co-design sessions to try to map on implementation strategies to the barriers. So we distilled down the barriers from the themes of discomfort, where the barriers are the pre-injury focus of the question, setting up false expectations, and patients, you know, concern about clarity, as well as patient and clinician concerns around how social needs information would affect discharge planning. So for patients, Spaulding has created a teaching video to explain why questions are being asked. In our co-design sessions, clinicians are starting to develop scripts to address key concerns, clarify the impact on discharge planning, and manage patient expectations, as well as delineating the role between case managers' role and patient role. And case managers have articulated this as, you know, I can set you up, give you the map of what to do, but you really need to execute on this plan. And then in the awareness theme on the concern of conveying inaccurate information to the next level of care, one idea is conducting a second screening with adapted wording on family planning day, which happens mid to later in the stay, and so that patients and family members can chime in and collaborate on these updated social needs, incorporating new functional injuries. And case manager said that, you know, this information should also be incorporated not just into the wheel, but also into the after visit summary for the next level of care, because the wheel really only communicates to MGB practitioners, and after visit summary is transferred to any organization following the rehab stay. Then finally, in assistance, there's this mindset shift. And more resources are needed. So these we haven't gotten to yet, but these are some ideas in terms of providing a case manager training that includes the scripts, disability-specific community resource worksheets, maybe, you know, early ideas around collaboration with SLP, since there is such a large proportion of cognitive communication patients who needs extra supports in screening and addressing needs. And then also just a need for other strategies because this is an evolving and new practice. And one of those might be a case manager champion. In future directions, there are many possible options. I've put in a grant to the LeaRRn Institute, and some other directions that we are thinking about is evaluating the implementation strategies on outcomes, whether it's implementation outcomes or actual healthcare outcomes down the road. And then one area that we didn't get to in this 5A's model is clinical adjustment, which speaks to the rehab therapists. We only focus on case managers primarily, but clinical adjustment, meaning how do clinicians in the rehab setting adjust their clinical care, whether it's PT, OT, or SLP, based on the social needs information. And then once all of this is in place, far, far down the road, if collection of social needs screening is consistent and systematic, the data is complete, these practices are in place, it would be really interesting to find out then what are the impacts on rehabilitation outcomes and readmissions. Here are acknowledgements, a lot of great people helping us out in this work. So thank you all, and just want to say thank you for attending and for your questions.